Hello friends, my name is Vaishnavi and I am also an MBBS student, and I was just wondering if we could revise together. So I decided to start revising all the topics, at least a topic a day from each year. I'm finally an MBBS student. So today we'll start with orthopedics and the topic would be bone tumors. So let's go. But before starting the video, if you like my content, please do like, share, and subscribe as well. Thank you. So, the bone tumors are mainly classified into benign and malignant tumors. What we need to remember for malignant tumors is that these end with sarcoma, and there are very few malignant tumors to remember, so it gets easier. Osteosarcoma, chondrosarcoma, Ewing sarcoma, angiosarcoma are the malignant tumors that end with sarcoma. Two tumors, that is multiple myeloma and adamantinoma, are the ones which do not end with sarcoma but are malignant tumors. Whereas benign tumors are osteoid osteoma, which is the most common benign tumor, followed followed by other tumors like osteoma, osteoblastoma, osteochondroma, and chondroma, osteoclastoma, also called as giant cell tumor, hemangioma, neurofibroma, etc. etc. Now we'll start with benign tumors of the bone. First tumor that we'd like to study would be osteoid osteoma. It is the most common true benign tumor of the bone. Clinical features: age 5 to 25 years. Most commonly affected bones are the lower extremity. Location is diaphysis, and characteristic feature of osteoid osteoma is nagging pain, which is worst at night and is relieved by salicylates, that is aspirin or any other NSAIDs. On for diagnosis, on X-ray, there we see a zone of sclerosis surrounded by radiolucent nidus, and the size is usually less than 1 centimeter. CT scan can be done just to confirm the diagnosis. And treatment is radiofrequency ablation therapy. Second benign tumor that we'd like to study is osteoblastoma. It occurs in the diaphysis and or metaphysis, but it never occurs in epiphysis. This could be a NCO types question. It occurs in the second decade of life, and most common sites would be jaw and spine. X-ray On X-ray, we see mottled appearance. Why? Because of there's calcification within the tumor, and lytic lesions are seen, which are surrounded by sclerotic zones. Third benign tumor is osteoclastoma or giant cell tumor. It is the most common bone tumor. Uh, it is a common bone tumor, and its nature is benign aggressive with local recurrence. On histopathological examination, we see undifferentiated spindle cells, multinucleate giant cells. That's why it was called osteoclastoma, which is misnomer, and it has high vascularity. Clinical features: most common age second to fourth decade, slight female preponderance, and sites are especially around the knee joint, which includes lower end of femur, upper end of tibia. Other sites include lower end of radius and upper end of humerus. Location: epiphyseal area. Chief complaints: patient presents with swelling, vague pain, or pathological fracture. On examination, we see swelling at the end of the bone, smooth surface, and tenderness. Eggshell cracking may or may not be elicited. For diagnosis, on radiological examination, we see the lesion which is solitary. It is either loculated or lytic. The lesion has expansile nature, soap bubble appearance, and no calcification is seen. For treatment, we have many treatment modalities, but the most acceptable one is extended curettage, in which we thoroughly remove the tumor tissue by use of burr, and we retain the native bone and the adjacent joint. We complete the removal by applying phenol, liquid nitrogen, or PMMA. We fill in the cavity by bone graft or bone cement or both, and we give external support in order to prevent the fracture. Second modality is excision. It is mainly done when the tumor does not really interfere with normal movements. Third modality would be excision with reconstruction. It is usually done when the patient presents late with the tumor. It has three ways. First would be orthodesis by turnoplasty procedure. Second is orthodesis by bridging the gap by double fibulae, and third is orthoplasty by autograft, allograft, or artificial joint. Fourth modality would be amputation. It is done if the tumor is more aggressive or it has recurred. Other treatment would be radiotherapy. It is done specially for the vertebral tumor, but again, the tumor has malignant potential, and the prognosis of the tumor after the treatment of the tumor, it highly recurs, and after it recurs, it gets more aggressive. We'll continue with the malignant tumors of the bone in the next lecture, and do let me know about the reviews, about if you have any suggestions, any complaints, do let me know in the comment section, and please don't forget to like, share and subscribe. Thank you.